everyone. Welcome you all for the IPNA endorsed webmaster series. Today we are into the last day of our webinar series of 2021, and it's a very special day to have all my teachers and all the three pioneers in the field to speak for us. The first talk is by Dr. Joseph Flynn, who's a world expert in hypertension, and all hypertension guidelines are almost charted by Dr. Flynn. And so we have him today to speak about ambulatory blood pressure monitoring. Dr. Flynn is currently associated with University of Washington Seattle Children's Hospital, and his academic interest is towards childhood hypertension and cardiovascular disease and chronic kidney disease. And he is also a recipient of Barnett Award from American Academy of Pediatrics for the year 2019, and he is also a recipient of Founder Award from American Society of Nephrology for the year 2020. Over to Dr. Joseph Flynn to deliver his talk on ambulatory blood pressure monitoring. Over to you, sir.
Thank you. Thank you for that introduction. And it's a pleasure to be here and participate in this course. And so today we'll talk about ambulatory blood pressure monitoring. I was asked to talk about how to do it, but then I thought I would also talk about some of our research using ambulatory blood pressure monitoring. So the talk has two halves. So we'll describe ambulatory blood pressure monitoring and then outline the approach to interpreting ABPM in children and adolescents. And then for the last part, I'll review some of our recent papers utilizing ABPM from a study called SHIP-AHOY, which is a study of cardiovascular risk in youth. So we know that there are many factors that can impact the accuracy of casual or clinic blood pressure measurements. Things such as body position, activity level, temperature. In infants, blood pressure is higher when they're feeding. The size of the cuff, of course, what kind of device you've used, and then are you in the clinic or out of the clinic. And when we are talking about manual blood pressure measurements, for example, by auscultation, there are problems there as well. Some of the same ones, including body position and activity level and cuff size, of course. But then we run into problems with terminal digit preference and observer bias. So how do we overcome these to get more accurate blood pressure assessment? That's where ambulatory blood pressure monitoring comes in. So in ambulatory blood pressure monitoring, the patient wears a lightweight device that takes the blood pressure at regular intervals, usually every 20 to 30 minutes for a 24-hour period. It allows assessment of blood pressure outside of the office and during the usual activities of the patient. It allows identification of specific blood pressure phenotypes, which I'll talk about. It's been endorsed for diagnosis and confirmation of hypertension. And as I'll show you in the last part of the talk, the results of ambulatory blood pressure monitoring are associated with target organ effects of hypertension and correlate with cardiovascular outcomes, at least in adults. So there are a variety of devices on the market. I'm not quite sure what's available in India. These are the ones that are available in the United States. They're all pretty small, relatively quiet. As I said, they take many measurements over 24 hours. We usually get about 55 to 60 readings in a 24-hour period. It allows us to capture blood pressure of the patient in many of their usual settings, particularly during sleep, which is very important. And you can see there's many types of devices available. So what are the benefits of ambulatory blood pressure monitoring? Well, first of all, it overcomes all the problems I've talked about with casual blood pressure measurement. There's no terminal digit preference. There's no observer bias. It allows assessment of blood pressure patterns, which I'll talk about in more detail, like white coat hypertension and nocturnal hypertension. It's been shown to enable detection of secondary causes of hypertension and provide a more cost-effective diagnostic evaluation. This slide comes from the 2004 National High Blood Pressure Education Program fourth report, which was the most recent American clinical practice guideline prior to 2017. And you can see that in that document, ambulatory blood pressure monitoring was said to be useful in certain circumstances and provide additional information, but there was no explicit endorsement of the use of ambulatory blood pressure monitoring in that 2004 guideline. Fast forward to the 2017 guideline put out by the American Academy of Pediatrics, which I had the honor of chairing the work group that put that together. And now the ambulatory blood pressure monitoring is recommended to confirm the diagnosis of hypertension after 3 high office blood pressure readings on different occasions to allow identification of white coat hypertension versus ambulatory hypertension. It's endorsed to evaluate blood pressure patterns in high-risk conditions such as coarctation of the aorta, diabetes, and chronic kidney disease. And then it's recommended to be used to assess how well patients with hypertension are being treated, including patients with chronic kidney disease, where actually a 24-hour mean arterial pressure goal has been recommended, and then in other treated patients as well. So what happens with the ambulatory monitoring studies? So the device records the blood pressure. The readings are downloaded to a computer, and then the blood pressure readings are compared to a set threshold value and then categorized as either normal or elevated. In adults, the wake blood pressure limit has recently been revised downward to 130/80. In pediatrics, we're still recommending the 95th percentile as the threshold, and I'll talk about that in a little bit more detail. And then the 24-hour monitoring period is divided into wake and sleep time, and you use the respective normal values for those time periods. So where do we get the normative data for pediatric ambulatory blood pressure monitoring? Well, at this point, the most robust data come from a study of 1,100 children in Central Europe that was conducted in the late 1990s, initially published in 1997 by Marianne Sorgel, and then later updated by Elke Rule in 2002. This data set has been endorsed by the American Heart Association and also by the European Society of Hypertension. It contains tables of mean systolic and diastolic blood pressure, as well as mean arterial pressure divided by sex for boys and girls. There are some concerns that have been raised about these data. A few of them quite obvious, that the mean blood pressure for boys is actually higher than the currently used adult ambulatory cut points. It's quite homogeneous population. It's all Caucasian children from Central Europe. And then the diastolic blood pressures were pretty flat, and I'll show you what I mean by that. So this is a graph of the diastolic blood pressures in that normative data, and you can see it like barely changes no matter how tall the child is, which seems odd, and it's probably an effect of the oscillometric technique used by the device that they used in their study. And of course, there are very complicated tables for the various parameters. This is one section of the table for girls. You can see it's divided by height, and there's various different parameters included. So from this, we can analyze a number of variables from the ambulatory studies, and we can use these variables to categorize subjects as either normotensive or hypertensive. And we'll talk about use of mean blood pressure load, and nocturnal dipping. Those are the ones that are used clinically. In research, there are other variables that are used for more sophisticated analysis of these studies, including blood pressure variability, hyperbaric index, and ambulatory arterial stiffness index, which actually may end up being fairly useful because it's a marker of vascular stiffness. So mean blood pressure, it's the average systolic and diastolic blood pressure for the full 24 hours for the awake and the sleep periods. We recommend that a diary is used to track the subject's sleep and wake times. Some people use an activity monitor called an actigraph, and actually in the model of ambulatory monitor that we are using at Seattle Children's, it includes an activity monitor, and that's very helpful when our patients forget to tell us their wake and sleep times. We calculate the means for the awake and sleep periods separately, and then we compare them to the threshold value from that table that I showed you an example of. So here's an example of a blood pressure tracing from a patient I saw, many years ago now. I probably need to update this slide, but you can see that we calculated the mean for the 24-hour period, for the wake period, and the sleep period, and we compared them to the threshold for the corresponding time periods, and you can tell without actually much difficulty that this particular patient had quite elevated blood pressure compared to the thresholds. And then we look at blood pressure load. So the load is the percentage of blood pressure readings that exceed the threshold for each time period. And these are calculated for the 24-hour study, the awake and the sleep periods. And why is this important? Well, it may help us to assess how severe the patient's hypertension is, and it may also allow us to make comparisons between different patients. And so again, looking at this patient tracing that I showed you a few moments ago, the loads there were very high for all the different time periods, and you can see the numbers there below the graph. And then we look at the blood pressure pattern. Is the patient dipping or not dipping? And what do we mean by that? So nocturnal dipping is represents the normal circadian variation of blood pressure. And so it's defined as the percentage drop in blood pressure during sleep. And it's calculated as the difference between the wake mean and the sleep mean divided by the wake mean. And we calculate this for both systolic and diastolic blood pressures, and we look at various patterns. Normal is felt to be greater than or equal to 10%, blunted dipping less than 10%, reversed dipping is where the blood pressure goes up at night, and then extreme dipping greater than 20%. And what are some conditions associated with non-dipping? Well, autonomic dysfunction for one, diabetes, which is very, I'm going to show you how important this is in diabetes in just a moment. Secondary hypertension. So Tomas Semen from the Czech Republic showed several years ago that children who had secondary hypertension had lower nocturnal blood pressure dipping for both systolic and diastolic blood pressure compared to children with primary hypertension. And then in obesity, in a study from our center, which I'll show you in a moment. So this was a paper published almost 20 years ago now by Empar Lurbe from Valencia, Spain, where they performed ambulatory blood pressure monitoring in young adults with type 1 diabetes. And they divided them into patients who had normal and abnormal nocturnal blood pressure. And you can see in this graph, in the top line, those who had abnormal nocturnal blood pressure were more likely to have developed microalbuminuria by about 5 years after that initial ambulatory blood pressure study. So non-dipping in type 1 diabetes was predictive of development of microalbuminuria. And then this is a study that we conducted a few years ago, where we compared dipping patterns in 247 children with obesity compared to 161 lean children who were seen at our center over about 7 years. What we found were that children who had obesity had blunted dipping and more often were non-dippers, and that's shown here, where the dipping was lower in the obese children than in the lean children, and more of them had a non-dipping pattern compared to the lean children. So putting this together, we get 4 blood pressure patterns by casual and ambulatory blood pressure, which are illustrated in this table. So if the office blood pressure is normal and the ambulatory blood pressure is normal, then that patient has normal blood pressure. If the office blood pressure is elevated and the ambulatory blood pressure elevated, that person has ambulatory hypertension. If the office blood pressure is elevated, but the ambulatory blood pressure is normal, that patient has white coat hypertension. And then if the office blood pressure is normal and the ambulatory blood pressure is high, that patient has masked hypertension. And this is a relatively straightforward way of categorizing ambulatory blood pressure studies. A more complicated way was presented in our 2014 American Heart Association statement, which again talks about the categories that I told you, and adds a category called prehypertension and a category called severe ambulatory hypertension, and incorporates blood pressure load. I'm not going to spend much time on this because I think it probably is going to go away soon. So what about white coat hypertension? This is defined as office blood pressure above the 95th percentile in patients who are normotensive outside of the office. It's felt to be a transient stress response. They call it the physician pressor effect. Very common in children. We see it between 25 and 40% of the children sent to our hypertension clinic. It seems to be less likely as the office blood pressure gets higher. And this is a tracing of a patient with white coat hypertension. On the x-axis are the hours of the day, And then on the y-axis are the blood pressures. The red is the systolic blood pressure. The blue is the diastolic blood pressure. There's a little black line, that's the 95th percentile. And you can see that the patient had a high reading out here when the monitor was placed, and then all the rest of the readings were normal. Their blood pressure went down at night. Then they had a few high readings during the day, but overall they had a normal study. The opposite of that is ambulatory hypertension, and so this patient had high blood pressures from the beginning of the study all throughout. First day, did go down at night, and then was high again on the second day. Now, what about masked hypertension? So this is where the office blood pressure is normal, but the ambulatory blood pressure is elevated. This is seen in patients with chronic kidney disease, kidney transplants, repaired coarctation of the aorta, and diabetes. In adults, masked hypertension is associated with increased rates of cardiovascular events, morbidity, and cardiovascular mortality. Masked hypertension in pediatric chronic kidney disease is associated with left ventricular hypertrophy. And detection of masked hypertension is one of the primary rationales for performing ambulatory blood pressure monitoring. And so I show you this tracing. This was an 8-year-old kidney transplant patient that we saw a few years ago who had relatively normal office blood pressure. And then when we did their ambulatory blood pressure study, they had a mean wake blood pressure that was elevated. They had elevated sleep blood pressure loads, elevated wake blood pressure loads, and blunted nocturnal blood pressure dipping. So a very abnormal ambulatory blood pressure study in a patient who had relatively normal office blood pressure, and this is typically what we see in kidney transplant patients. And then this study was part of the chronic kidney disease in children study, where we looked at children in the cohort who had echocardiography done as well as ambulatory blood pressure. The overall prevalence of left ventricular hypertrophy in the cohort was 17%. When we looked at their ambulatory blood pressure profiles, 38% had masked hypertension and 18% had ambulatory hypertension, but the prevalence of left ventricular hypertrophy was similar in those with masked hypertension as in those with ambulatory hypertension, and was higher than those with normal blood pressure. And that's shown in the graph here, where the patients are divided up according to their blood pressure category. Note that there were almost no patients with white coat hypertension in the chronic kidney disease group. And you looked at the masked hypertension group and the normotensive group here on the far left, and the confirmed hypertension group, and the prevalence of LVH was much higher in the masked and confirmed hypertension group than those who had normal blood pressure. So to summarize this part of the talk, we assessed the ambulatory blood pressure monitoring results by calculating the wake and sleep mean blood pressure and blood pressure load. We are currently recommending the classification scheme from the American Heart Association paper with the rule normative data. There is some chatter out there in the community about whether we should be changing our approach to ambulatory blood pressure monitoring in children now that the adult ABP cut points have been lowered. And more to come on that is all I will say. And we combine the office and ambulatory blood pressure to categorize the blood pressure phenotype into normal, ambulatory, white coat, and masked hypertension groups. Okay, I want to talk to you about 3 papers that we have published from a study that's called SHIP-AHOY. And this is a cross-sectional study of 400 youth between the ages of 10 and 18 who were recruited at 5 centers in North America with blood pressures ranging from completely normal to about the 90th percentile. And the intent of the study was to look at the relationship between hypertensive target organ damage and different blood pressure levels. And ambulatory blood pressure monitoring was a key component of that, of our study. And so what I've done is I've pulled 3 papers out and basically thought about them as ways to answer questions that come up about use of ambulatory blood pressure monitoring. So the first question is, well, when should we do it? What patients should we be doing ambulatory blood pressure monitoring in? And so the title of this paper, which came out about 3 years ago now, is Prediction of Ambulatory Hypertension Based on Clinic Blood Pressure Percentile. And so, you know, as I've talked about, the American Academy of Pediatrics Clinical Practice Guideline recommends ambulatory blood pressure monitoring be done to confirm the diagnosis of hypertension after 3 readings at or above the elevated blood pressure or stage 1 hypertension level, and after 2 readings at or above the stage 2 hypertension level. However, ambulatory blood pressure monitoring might not be universally available. So the question comes up, is there an office blood pressure level that is strongly associated with ambulatory hypertension, which should, you know, make us want to do ambulatory monitoring in patients with blood pressure hits that level? So what we did was we analyzed office and ambulatory blood pressure data from the first about 250 participants in the study. We looked at the sensitivity and specificity of different clinic blood pressure percentiles and cut points for the prediction of ambulatory hypertension. And what we found was that the prevalence of ambulatory hypertension increased as the office blood pressure percentile increased. And this is not new. We've known this, and I think I actually mentioned that before. And what we found was that the 85th percentile of systolic blood pressure from their tables in the clinical practice guideline had about the same sensitivity, but better specificity than the elevated blood pressure cut point, which is 90th or 120, to diagnose ambulatory hypertension. And so here you see the prevalence of wake or sleep systolic or hypertension based upon the clinic blood pressure percentiles. And in this slide, we compare the clinic blood pressure percentiles between the 4th report in the black bars and the CPG in the blue and the light gray bars. And you can see that as the office blood pressure increases, the prevalence of ambulatory hypertension increases, with the 4th report cut points performing a little bit better. Of course, they were higher, and so that's not actually surprising. And then when we looked at the sensitivity and specificity, the 85th percentile seemed to have the best balance between sensitivity and specificity. And actually, 120 was not, did perform relatively well also. And so we basically concluded that adolescents with office blood pressure at or above the 85th percentile should undergo ambulatory monitoring because of the strong association with ambulatory hypertension. We had many participants who had office hypertension that had normal ambulatory blood pressure, which is not surprising because these young people had relatively low blood pressure. And why is this important? Because we feel it may allow optimization of ambulatory monitoring use when the availability of ABPM is limited. So the next question we looked at was, how does tolerability of ambulatory monitoring affect the results? And actually, I think, certainly in my practice and for those of you who have used ambulatory monitoring, it is not infrequent that patients complain about being disturbed by wearing the monitor. And so we wanted to see whether that would affect the results. And so we looked at the tolerability of ambulatory monitoring and its impact on the results in about 232 participants. At the time of the monitoring, they were asked to answer a question about rating the tolerability of the study, and that is illustrated here in the next slide. So they were asked to just give a ranking of a 1 to 10 scale. How much did it bother you when you were awake versus sleep? Higher number meant it bothered you more. And responses of 8 or higher were considered indicative of poor tolerability. It was not surprising that more of the people tolerated ambulatory monitoring poorly during sleep. And poor tolerability actually led to slightly poorer quality ambulatory monitoring studies. So this is the effect, the association of tolerability on the success of the study. And so here, those who are intolerant had a lower percentage of successful readings in here, so you can see it is lower. This was during number of successful readings was lower, and the percent of successful readings was lower in those who rated it poorly. When we looked at the results, we found that intolerant participants had more ambulatory hypertension and more sleep hypertension. So you can see that for all of these, those who are intolerant were more likely to have wake hypertension, sleep hypertension, and the same for systolic and or diastolic. So overall, poor tolerability led to more frequently abnormal studies, so you do need to think about this when interpreting ambulatory monitoring studies. And then finally, our most recent paper looked at what level of ambulatory blood pressure is associated with left ventricular hypertrophy. And this is important because we want to identify which children are at increased cardiovascular risk. This is one of the most important uses of ambulatory blood pressure monitoring. And so we looked at different ambulatory blood pressure criteria, including adult and pediatric criteria and blood pressure load as predictors of left ventricular hypertrophy. We had 327 adolescent participants. We calculated the sensitivity and specificity of various ambulatory blood pressure cut points. They were about 16 years old, more males than females. Majority were white. Median BMI percentile was 90 to 92nd. So this is a relatively overweight group. 62% had overweight or obesity. The mean left ventricular mass index is given here. About 21% had LVH based upon left ventricular mass index above the 95th percentile. And what we found, very interestingly, is that the new adult cut points from the American College of Cardiology, American Heart Association guideline identified more participants as hypertensive than use of the 95th percentile from the WUL data. And so I'm going to show you, I know you can't see anything in that, I'll make it a little bit bigger. So this is comparing their hypertensive status using adult or pediatric criteria. You can see that the awake hypertension was more often seen using the adult criteria. Probably not surprising because the adult criteria are normal. This was the awake hypertension, and then the same is seen for the sleep hypertension. Actually, the sleep numbers in the ACC guideline are really quite low. And then we looked at what is the sensitivity and specificity for prediction of left ventricular hypertrophy, and the best balance of sensitivity and specificity came in at 130, which is the adult criteria for ambulatory blood pressure monitoring. So basically, we saw that mean systolic blood pressure and systolic blood pressure load were associated with left ventricular hypertrophy. We looked at comparing mean blood pressure versus load, and there was really no better predictability based upon the area under the curve. There was no association for diastolic blood pressure parameters. And then the only thing that fell out in the multivariable analyses was that only mean blood pressure was associated with LVH. Addition of blood pressure load did not improve the prediction. And so this is a very important point that may end up impacting future blood pressure guidelines, we think. So just to pull it all together, these are some resources that if you want to take a screenshot, do it now. This gives you the AAP clinical practice guideline, the 2014 pediatric ambulatory blood pressure monitoring statement, and then also, importantly, listings of ambulatory blood pressure monitorings that are validated for pediatric use. And so this may be helpful for you. And then I thank you for your attention, and I am happy to take any questions at this point.
Thank you for providing the ceiling knowledge of hypertension, sir. It was really an interesting and inspiring session. Many of us have our own questions as well and doubts, but we'll take up the questions at the end of the session.
Okay.
And so we'll move on to the next speaker. The next speaker is Dr. Georgi Abraham. I'm very much proud and privileged to introduce my teacher who has been a pillar of support for many years. Dr. Georgi Abraham is a senior consultant nephrologist at MGM Healthcare, Chennai, and he is also adjunct professor at IIT Madras and Tanker Foundation. He has got n number of national and international awards, and he is a recipient of internationally distributed medal in nephrology for the year 2003 by American Kidney Foundation, and he is also a first recipient of Diamotis Orophilus Award for lifetime contribution to peritoneal dialysis, which has been awarded by International Society of Peritoneal Dialysis, and he is also a recipient of Robinson Award in the year 2015, and he has received from International Society of Nephrology, and he has got n number of national and international publications. And he has recently authored a textbook, autobiography. It's My Patient, My God. I think the title of the book per se denotes that his dedication for his patients. Over to Dr. Georgi, sir, to deliver his talk on renal transplant in India.
Yeah. Dr. Kalaivani, thank you for that kind introduction, and also alluding to the fact that I am your teacher. Now you have become my teacher because I call you for pediatric consultations, because pediatrics is a very difficult area, especially with regard to chronic kidney disease. Basically, I would like to also thank Dr. Kumud Mehta. I see her name here, and Dr. Namalwar and other members of your organization, especially Mehta Hospital, for giving me this opportunity. And your passion for education is endless. You are a role model for many because you have been conducting all these educational activities for quite some time. And I am very proud of you as a colleague, as a student. So I shall dwell on kidney transplantation in India, past, present, and future. Okay. So when we go to the past, the first kidney transplant was done in CMC Hospital, Vellore, by the team Dr. K.V. Joni, who is still alive. He is a professor and he lives in Kerala, and Professor Mohan Rao, the transplant surgeon, and the team group. So Mr. Shanmugam received the first transplant. This is the picture of Mr. Shanmugam. And then you can see a series of patients who received the transplantation at that time in the 70s and the early 80s. And the only immunosuppressive medication available at that time was prednisolone and azothioprine. And I am sure that you heard that one of the patients from Vellore who received a sibling transplant is doing very well in North India, 40 plus years, and on the same immunosuppression and haven't changed the immunosuppressive medication. When we talk about transplantation, there are three important elements. One is cost, next one is quality, and the third thing is accessibility. We are fortunate in Tamil Nadu that we have all three elements are there, and we can take care of our patients because we have enough gifted people and also trained people to take care of this patient. So when they did the first transplant and they had to send the blood by flight to Delhi through the cross match between the recipient and the donor by Dr. Kamala Balakrishnan, and who was living in Delhi. And Kamala also became a very important personality in tissue matching in the world, and I have met her personally quite a few times. Next. So this shows evolution of renal transplantation in India over the last 4 decades. This was published in 2010, the NDT, and I just want you to look at the cumulative probability of survival and up to 480 months. So when you look at the 1970s to 79, the survival is quite low. And as you move to 80 to 89, the survival became better. D stands for death and GL stands for graft loss. And in 90 to 99, the graft survival is, the cumulative probability of survival is much higher, and 0 to 2007, it is much higher. So this shows that we have matured in our transplant programs, and we know how to take care of these patients. And as I said, our quality is good, our accessibility is good, and our cost is the cheapest in the world for kidney transplantation. So this shows the graft survival by HLA match between 1986 to 2007. We know that the HLA was in primitive in 1986, and we now look at the epitopes rather than just HLA class 1 and class 2. So if you had, look at this graph again, and if you had good HLA match, the graft loss was less and the survival was. So if you had 2 to 3 HLA and then less than 2 HLA match, the graft survival was lower. So there it is spreading out as you move forward. So HLA plays an important part in the transplantation, and I will dwell upon that as we move forward. Now, what are the goals of transplant? There should not be any acute rejection, no adverse drug effects, 100% patient survival, 100% graft survival, and is it really possible? I am sure that in years to come, in future, this may become possible. Not 100% patient survival, but 100% graft survival, and probably no adverse drug effects. So this cartoon shows the challenges in transplantation. You have medical, you have immunological and psychological challenges. And this showing higher risk. Who are the immunologically challenged people? Those who had previous pregnancies, those who had multiple transplantation, multiple transfusions, and previous transplants. They may have preformed HLA antibodies. Psychological. Those, especially those who have diabetes, they also have depression and other things because of the multi-organ involvement. And then there are medical risks, such as those with coronary artery disease, previous malignancies, and peripheral vascular disease, previous stroke. These are all high medical risk. And then you have, as I said, sensitized patient, subclinical rejection. We recently had a transplant about 6 days ago. Mother donating to a daughter. Everything was fine. Even the PRI was normal. And yesterday, the creatinine all of a sudden jumped day before yesterday. So we did a biopsy of that. We never treat patients without. And there was some subclinical rejection. And the C4D was negative. Then you'll end up with chronic allograft rejection, which will lead to graft loss. So monitoring anti-HLA antibodies, MICA antibodies, Luminex beads with absorbed single HLA antigens. These are all important, and we may have to use these tools in patients to promote an effective and successful transplantation. And we need to look at approaches to tolerance. So risk factors for acute rejection: A is universal agreement, B is majority agreement, C is single study. Most important thing is the number of human leukocyte antigen mismatches. I have already alluded to that. And then there are other B's. Panel reactive antibody should be 0 and not more than that. So rejection, recognition and immune response to the allograft by the recipient's immune system, resulting in allograft destruction. Starts with the placement of the allograft. Donor antigens enter the systemic circulation and lymphatic system to access the secondary lymphoid system, where naive T cells are activated. Donor cells leave the allograft, and the recipient cells then enter the allograft. This results in direct and indirect allo recognition. As shown here, this is a cartoon which shows the kidney, and this is the lymph node which is shown there, and spleen is also a part of it, how the rejection takes place. Now, sorry about this busy diagram. What is HLA system? The human leukocyte antigen system is the name of the major histocompatibility MSC in human. This group of genes resides on chromosome 6 and encodes for cell surface antigen presenting proteins and has many other functions. The major HLA antigens are essential elements for immune function. You have different classes. The class 1 is A, B, and C, and these are peptides present inside the cell, and these peptides are produced from digested proteins. And then HLA class 2 are predominantly DQ, DP, and DR. They present antigens from outside of the cell to the lymphocyte. And then the HLAs corresponding to the MSC class 3 encodes for components of the complement system. So these are all important in immunological testing to look at the transplant and the life of the transplant. This cartoon shows the HLA, the sixth chromosome, the PEEP, the short arm and the long arm. The HLA is shown here. So HLA class 1, A and B expressed on all nucleated cells. Class 2, D are found on B cells, dendritic cells and macrophages. And the antigen-presenting cells are dendritic cells, macrophage and B cells. And the antigen-presenting cells express also co-stimulatory molecule to activate the T cells. So HLA cross-match. Cross-match is a measure of donor-specific pre-sensitization in the potential recipient and can be carried out using number of different serological and cell-mediated methods. But the most common which we use, which is the cheapest, is the CDC lymphocytotoxic cross-match between the recipient serum with the donor lymphocyte. You can also separate the T cells into T and B cells and do a cross-match, and also autoantibody detection tests with the recipient serum with the recipient lymphocyte. IgM antibodies are innocuous. These are all autoantibodies, whereas IgG antibodies can lead to graft loss. Immunosuppression is defined as the prevention of the interference with the development of the normal immunologic response. The immune system recognizes an allograft as a foreign body and will mount vigorous immune response against the allograft in an attempt to destroy it. Immunosuppression with medication is necessary to prevent destruction of the graft by the immune system of the recipient. Goals of induction. Degree of depletion of lymphocytes. We said the lymphocytes are responsible for B and T lymphocytes. Thymoglobulin is 83 to 92% with a single dose produces depletion of lymphocyte. Time to induction is minutes to hours to days. Duration of lymphopenia, peripheral lymphocytes and lymphocyte subset can be measured and can be calculated, and this will help you in taking the induction forward. Now, I just want you to look at the induction therapy. I want you to look at this is American data, immunosuppression in adult kidney recipients. First, post-transplant here, immunosuppressant trends in US transplant recipients reveals most patients who receive lymphocyte depleting induction antibody, that is either ATG or alemtuzumab. So when you look at that, it is shown here the year 2004 to 2014 in all of these, and you have the percentages are shown there, and you can see that T-cell depleting agents have become nearly 80% as the induction therapy, not IL-2 receptor antagonists or none. Most of them have induction therapy. Then you look at calcineurin inhibitors. So it has gone up from 64% to almost above 90% tacrolimus compared to cyclosporin. The use of cyclosporin has come down remarkably. Next one is antimetabolites. We were using initially azathioprine. It remains flat, but mycophenolate mofetil is the preferred agent. And then mTOR inhibitors at transplant, they have 1 year post-transplant, they have declined in use. And then steroids. Steroids, we still use it. Steroids are one of the most important mainstay in the transplant in the immunosuppression. And some people use immunosuppression sparing steroids, but I don't use that in my practice. Now, this is a data which we presented in blood purification. And when you look at that, I just want you to look at the diabetic nephropathy, chronic glomerular nephritis, and hypertensive nephrosclerosis are the most common. The color bar is shown here. And when you look at the transplantation, renal transplant, it is shown in black in India. The current management of most CKD4 and 5 patients involves conservative and palliative treatment are shown here. But now the situation has changed with the PMJAY, so the number of transplants are less. So we do about 11,000 transplants a year in India now, which is quite an insufficient number of transplants, looking at the number of patients who require transplants. When you look at no diabetes and diabetic patient, it is shown here the transplant for the non-diabetic patient, it is about 18%. And 1, 2, 3, and for diabetic patient, it is about 9.3%. So we are avoiding diabetics from transplant. Let me take you. This is one of the young boy who has received a transplant about at the age of 8. So here is the HLA match. What is given in orange is a match between the mother and the son. And then he had class 1 antibodies were negative and class 2 antibodies were negative by panel reactive IgG antibodies. And let me take you further through his life. I saw him today also, 5 years post-transplant. So when you look at that, everything is shown in this. And this is the from 2016 till now, his height is shown here in the blue. He was 130 centimeters. Today is 158.2 centimeters. And this one shows his weight. His weight has also gone up. But lately he has been strict about his diet and his weight has gone down. And this shows the kidney function are shown in the blue by the creatinine level, and he is on triple immunosuppression, including prednisolone 5 milligram, alternating with 2.5 milligram, and he is on tacrolimus 0.75 and 0.5 milligram, and mycophenolate mofetil 180 milligram twice a day for 5 days, and 180 milligram once a day for 2 days. And his latest tacrolimus level after 5 years is 5.6 nanogram, which is a trough level. So these are all shown here. I have already alluded to about that. And this is his, from the mother, you know, and the serum creatinine is shown there. I will just skip these slides. And the medication dosage is shown here, as I already alluded to. And then this is another one. Can we transplant our diabetic patient? And who should be the donor? This is a live kidney transplant between a diabetic mother and a diabetic recipient. In exceptional circumstances, we can use diabetic donors. This is a mother who was giving because his wife was willing to give the kidney, but we found that she has got a 4-month-old baby and another young child. And when we looked at her renogram, we found that one of the kidneys, there's a difference of kidney function between two kidneys, about 15%. So we looked at the mother, and the mother had no diabetic disease. She had good cardiac functions, and when echo normal, 68%, ECG was normal, and the kidney function, split kidney function is shown here, the GFR is shown there, and her ACR was 6 milligram of albumin per gram of creatinine. And we found that her BMI was okay. She was B positive. She's a diabetic for 18 years on oral hypoglycemic agents and insulin. And the serum creatinine was 0.55 milligram. Hemoglobin A1C was 8.6, but we had to strictly bring her sugar down. And we found that she's hepatitis surface antigen positive, but there was no viral load detected. So she was put on endecavir, and look at the recipient, son. And he had normal epicardial coronaries. He had global hypokinesia. The ECG was normal, and his anti-HBs antibody was over 500. I got an infectious disease consult. They reassured me that this will not be transmitted to him. Very unlikely, because he has an anti-HBs antibody level of over 100. This is isotope renogram showing. This is the angiogram of the kidney. So we took the left kidney and was transplanted to the son. So the message I want to give is, we can use even diabetic patients as donors, and we can be safe, provided they have no coronary artery disease. And this will enhance, with a reasonably good HLA match, this will enhance the transplant, and the mother will feel very well, and the son will also feel very well. So this is the HLA match. They had haplotype between the haplomatching between the mother and the son. And the 6th post-operative day, the blood pressure was 120/70. Weight is shown here. Serum creatinine is 1.34. Fasting blood sugar of the recipient 111, and his immunosuppression is 0.5 milligram per kilogram body weight. Prednisolone, that is 40 milligram. Tacrolimus 4 milligram BID, and then MMF 1 gram BID. So let me show you another one. How successful are diabetic getting kidney transplant? This is one of my patients. He's 73 years old. He was transplanted 21 years ago. He has diabetic retinopathy, autonomic neuropathy, and nephropathy. Underwent a live kidney transplant in 2000. No rejection. Currently, serum creatinine is 1.3 milligram. Urine analysis is normal. No microalbuminuria. Is also on an ARB. And what is important is every diabetic who is transplanted, an anterior segment and a posterior segment should be seen with a dilated fundoscopy, mandatory every year. And his immunosuppression currently is mycophenolate mofetil 500 milligram OD, cyclosporin, that is neural 75 milligram in the morning and 50 milligram in the evening, and prednisolone 2.5 milligram. And he has no coronary artery disease. He's very strict with his diet. And this shows that how many diabetics will live on dialysis for 21 years? Hardly anybody. So this shows the success of a transplant in diabetic population. So contraindications for transplant are malignancy, active infection, active malignancy, active infection, psychiatric disease, alcohol dependence, drug dependence, cardiovascular comorbidities, and morbid. I just want to bring to your attention HIV. We have transplanted HIV patients, but they have the virus there, but the viral load is undetectable, and their CD3 levels are high, suggesting that they have to continue antiretroviral therapy, and the immunosuppression should be tailored to such a level that they should not develop any infection. This man also had Kaposi sarcoma. He's a patient from Tanzania, and with metastasis, he was completely treated, and he was free of Kaposi sarcoma when we transplanted him. Now it is nearly 3 years. He is doing very well, minimal immunosuppressive therapy. Now, our immunosuppressive regimen is tacrolimus 0.1 to 1.1 milligram per kilogram, 2 divided doses. Cyclosporin, when we are using it, 8 milligram, and MMF 750 milligram BID or 1 gram BID, prednisolone 0.5 milligram, and induction agents. I have used basiliximab, I used daclizumab, but now I am with single dose of thymoglobulin. So the potential predictors of outcome, recipient factors are age, gender, race, cause of ESRD, diabetic kidney disease. Donor factors are deceased or living transplant. Age also plays an important role. Pre-transplant, the history of the recipient, coronary artery disease, peripheral vascular disease, GI liver disease, respiratory disease, especially bronchiectasis or pulmonary tuberculosis, cancer, tobacco, time on the waiting list, and delayed graft function. So this is our study. We looked at patients who were 40 to 60 years, published by Kalivani's classmate Ashik Ali, is a radiologist now, looking at patients 40 to 60 shown here, and above 60, and this is the death censored graft survival at 5 years. It is not statistically significant. And then the patient survival also at 5 years is not, but after 5 years in the elderly group, there is a drop in the survival because of death. I just want to show that this particular study had 40 to 60, 181 patients, and above 60, 44 patients, and 45.36 were diabetic in this young group, and about 60% were diabetic in this group. So it tells you that diabetics should not be excluded from transplantation, and they should be offered transplantation. So the first multi-donor transplant was done by us in 1995. It is reported in Kidney International. Nobody can dispute it because it is a recorded thing. We used 2 kidneys and a heart at the Madras Medical Mission Hospital. And Hindu asked me to about many years after that. So they highlighted that in their publication. Now, economics of transplantation, finances, cost versus charges. I said cost is a very important thing. The economics of ESKD, hemodialysis, peritoneal dialysis, transplantation, live versus disease. We all know that transplant is the best treatment for anybody, irrespective of age. And cost of immunosuppressive drugs also plays a major role, whether they are being reimbursed or whether they get it free from government or they have to pay from their own pocket. So Indian statistics, 1% of the world automobiles, 6% of the road traffic accident of the world, 17% of the world population we have and the death due to road traffic accident is 150,000, whereas all over the world it is 1.4 million. And the GDP per capita income is shown here, and most death is due to two-wheelers. So Transplantation of Human Organs Act, you know that from 1994 we have moved all the way to 2011. So overcoming challenges in disease donor transplantation. You have a state health department, they are doing a wonderful job in Tamil Nadu. The government hospitals, public at large, the private sector hospitals, and the NGOs like Mohan Foundation and Tanger Foundation. So should we use an implantation biopsy? This is a paper which we published, and we found that implantation biopsy definitely helps us in finding, especially with disease donor transplant, the quality of the graft, as published in this paper. Now, the phases of transplantation is depicted in this slide. You have a transplant given, you have an induction therapy. Here, days are shown here, weeks and months and years on the horizontal axis. And you have early acute rejection in the early part, early intense immunosuppression, then late rejection on maintenance immunosuppression, and chronic rejection. Can late rejection happen? Yes, it can happen if the patient is not compliant with medication, or if they have an infection. For example, we had a number of COVID patients. One of my COVID patients, despite having acute rejection, and we treated it with Solometrol, her kidney function from 1.5 creatinine has gone to 4.5. So late rejection are very difficult to treat, even though they are acute rejection. Now, this is our experience. People use multiple doses of induction therapy with immunoglobulin. See, in India, we have to tailor our treatment, and we cannot be like Americans or Europeans or Africans. So this is one of our publications using single-dose thymoglobulin as induction therapy. This is what I do. And the acute rejection is shown here, 7.1%. Cadaver donor management includes referral for donation by the primary care team. We were doing it in Ramachandra for many years. Verbal family interest for donation. Direct donation, donor identification and management, non-heart beating donation after withdrawal of care. The suitable organs depend on the donor age, medication restrictions, malignancy, and primary brain tumors. This is the worst thing which can happen. We all know that a lady from Germany came to India. She was in North India, and she went back to Germany, and she had a sudden encephalopathic death. Her organs were removed, and she had rabies, and the recipients all had rabies, and they died. So hepatitis B and C infections, but we now do transplant with hepatitis B and C, cytomegalovirus, IgG, IgM, EB virus can lead to lymphomas, other viruses, syphilis, and then tuberculosis. We have to treat them, but we can do after 2 months of active 4-drug therapy if the disease is not progressive. Fungal infection, definitely an absolute contraindication, and poison as a cause of donor death, rabies, absolute contraindication. So this is Sunil Shroff's publication in Indian Journal of Transplantation, 25 years of transplantation law in India, progress and the way forward. This is kidney transplant, and from in 2012 to 2017, and we have moved, definitely there's a steep increase in kidney donation and disease donor transplantation in the country. Now, long-term outcome of disease donor renal transplant in pediatric patients by Vivek Kute. It is shown here. The number of children were 37. Mean P recipient of all received ATG and immunosuppression over a mean follow-up of 3.39 years. Patient and graft survival rates were 72%, 72.9, and 83.7, which suggests that renal transplantation probably the best treatment for children waiting or waiting with renal replacement therapy. So, outcome of renal transplantation from deceased donors by Vivek Kute, shown the standard criteria donor, extended criteria donor, and donation after cardiac death. It is shown in the graph here, and you can see that the graft survival censored and survival censored, patient survival censored over a period of 8 years, you can see that very good graphs and patient survival. So poison donors are source of this we have been doing in Ramachandra Medical College. We have used, and I just want to highlight who were these poison donors. We had snake venomation, especially cobra bite. We have 45,000 people dying in India due to cobra bite. Can we use them? There are only very few instances, and we have used that. Then road traffic accident victims, stroke and intracranial bleed, partial hanging we have used, poison donors, cobra bite victim, and suicidal and accidental poison. This is the first case report in the world published in Transplantation of cobra bite victims, and there are 4 recipients who have received the transplant. One of them was still alive in Chennai 22 years after the cobra bite victim's kidney was used as deceased on a transplantation. This was published in 2010. So you can also land up. This is a murder case against me for a family feud for a deceased on a transplantation. So I have learned a lot of lessons. And in my book, My Patients, My God, I have devoted one chapter how I overcome these difficulties. So ISOT 2018 in Hyderabad, you can see Dr. Shroff, Anil Chandarkar from Boston, Francis Lolmaniko, who was the past president of the Transplant Society, Vivek Kote, myself, and this cardinal from Pontifical Seminary in with Vatican, talking about the ethics of renal transplantation. They were the WHO team. So how disease? So we have number of publications. I'm just showing disease renal transplantation program in India, published in 2010 in Transplantation, then also in Kidney International. So complications of transplantation, it is related to immunosuppression. So I strongly appeal to my colleagues, do not follow what the Americans and the Europeans say regarding tailoring of immunosuppression. We need to develop our own programs because our patients, most of them die of infections following transplant, and less patients die of cardiovascular disease. So my appeal is you need to tailor the immunosuppression. And infection and malignancy, metabolic complications, malnutrition, it could be obesity, protein energy wasting, hyperlipidemia, new onset diabetes, very common in our transplant programs, hypertension and chronic rejection. I am coming to the last slide. So complications, viral infections, herpes, wound infection, so Kaposi sarcoma, and this is the last slide. More diabetic patients for life and disease on a transplantation. We need to take the diabetics because 1 in 3 diabetics develop kidney disease. India will emerge as a leader of transplantation, being a G7 nation because of our population and the experts and the skilled people we have in our country, and the pharmaceutical which support us with the with the cost-effective medication. Survival will improve with curtailing infections, coronary artery disease and malignancy. Children will grow to be adults, lead a fruitful life after transplantation. Just now, Kalevani will know that. This is the first time in the world I looked at the registry. Nobody has become pregnant after 20 years of successful transplant. She's an MD doctor, and Kalevani is smiling, and she just delivered normal delivery, a baby which weighs 3.1 kilograms 2 days ago after being on transplant, successfully transplanted for 21 years. And so this is something, I felt personally, I have pride, and also I'm sharing this with all of you, that this is a history we create. Thank you for your kind attention.
Thank you so much, sir. It was really an excellent talk, and thanks for sharing all your personal experiences, bitter and the best experiences with us. Thank you so much, sir. We'll move on to the next speaker, Dr. Kumud Mehta. I'm privileged to introduce Dr. Kumud P. Mehta. She is a senior pediatrician and consultant pediatric nephrologist at Jaslock Hospital and Research Center. She is also a visiting consultant at Wadia Children's Hospital, Mumbai. Her area of interest is towards preventive pediatric nephrology, chronic kidney disease, and kidney transplant in children. She is a recipient of Lifetime Achievement Award, which is awarded by Indian Academy of Pediatrics, and she has also received several Lifetime Achievements Award from Indian Society of Nephrology and Indian Society of Pediatric Nephrology as well. She's received a Lifetime Achievement Award recently in the year 2019, and she's been a counselor from India between the year 1989 to 1995 by International Pediatric Nephrology Association. Over to Dr. Kumud Mehta. She is one of the senior most pediatric nephrologists in India. Over to Madam to deliver a talk on preemptive kidney transplantation.
Thank you very much. Thank you very much, Dr. Kalaivani, for the nice introduction that you had. I feel very small in front of two marathon speakers, one pioneer in hypertension and the second one, my dear friend, Dr. Abraham, who had given me the Tanker Award. He found me very, somehow or the other, deserving. And also his work is something outstanding. Compared to that, I'm a doctor of a small children in a small hospital where the pediatric nephrology began way back in 76, that is by Jarbai Wadia Hospital, which was built for the primary care of the children born across into the maternity section and for the routine care of these children so that they should grow into healthy babies. And that is the site where I started the pediatric nephrology along with Dr. Nammalwar in Chennai and Dr. R.N. Srivastava in AIIMS. And the beginning was auspicious because I never thought that we will reach the transplant level in these children who suffered from chronic kidney disease and deserved a better classification of their chronic kidney disease and also better treatment right from the day one. So my main intention was early diagnosis of chronic kidney disease by simple tests which were available for the pediatrician since we don't have enough pediatric nephrologists. But soon I realized that that's not the end of the story. They deserve the last treatment which the adult nephrologist had given to their patients, and that was only possible with a private and public, sort of a partnership. And that was offered to me sort of on platter by Jaslok Hospital and Research Center by appointing me as a pediatric nephrologist to assist their pediatric nephrology transplant. And since 1986, I'm with Jaslok Hospital. My main purpose is to take the children from the Wadia Hospital, deserving children, to Jaslok Hospital, which is a world-class multi-specialty hospital. Next. And I give them the same treatment like any other adult patient which was receiving at Jaslok Hospital. So in short, I began in 76 by a very modest beginning of keeping the OPD registry for all the children who are diagnosed with kidney disease. But we didn't have the research lab or we didn't have the sophisticated renal function tests. We didn't even have ultrasonography or peritoneal dialysis backup for AKI, and the kidney biopsy was also not there. So with these handicaps in 1993, we soon realized, and we had low resources, but we collected the donations because the Wadia could not afford that. And soon we had an international conference of glomerular disease, again endorsed by IPNA. So at this stage, I think I forgot to thank IPNA for this wonderful webinar and for inviting me to be a faculty on this. And I again and again, sort of appreciate that help at every conference of mine. By 1996, with all the addition of the renal lab, ultrasonography and kidney biopsy by all the three methodology, we had made a mecca for the further diagnosis of kidney disease right up to the what the international nephrology department had guidelines for. That means in steroid-resistant nephrotic syndrome, we had enough number of kidney biopsies to support the diagnosis of FSGS. Since today's webinar addresses the Pediatric Glomerular Disease Symposium, I would like to stress, but then at the onset, I must guess that, we can't separate glomerular diseases, whether it started in glomeruli or whether it started in a tubular interstitial disease in many cases, because they are allowed to proceed further. And at the end of it, even the kidney biopsy cannot distinguish where was the beginning of the kidney disease. In 1996, we acquired the honor of being a training for the CMEs on different renal diseases in developing countries with low resources. And still we didn't have hemodialysis. But in 2000, because of sudden increase in the spate of hemolytic uremic syndrome, D+, we were forced to also add hemodialysis on those patients who did not respond to peritoneal dialysis. So that was the beginning of the hemodialysis, and subsequently the progress was halted because the kidney transplant was not allowed in the pediatric hospital because the donor surgery could not be done in a pediatric hospital, and we had to look for help. And here comes again our savior, that is the Jastrow Hospital. By now, the Jastrow Hospital had done robust adult kidney transplant. 2,056 adult kidney transplant were done, out of which 100 were pediatric transplant. So you could see a very small numbers of pediatric end-stage renal disease required transplant. And we decided that it is worth, asking the help of the big brother, that is a adult kidney transplant. And the cases which were referred for kidney transplant in children at Jastrow Hospital initially came from all kinds of specialties, including the pediatric nephrology clinics from outside Jastrow Hospital. Some of them adult nephrologists who were diagnosing kidney diseases in children and had this end-stage renal disease in children, and they were sending. Some of the cases were directly coming from intensive care with hemodialysis, and not with what has caused it, had sent it to the adult nephrologists, and others were of unknown origin. So there was a mixed bag, and that was very unsatisfactory. And so in 2000, we decided to go into the depth. I was alone, but I had very enthusiastic youngsters who joined me, and we decided that we must start a kidney transplant for children with end-stage renal disease from unprivileged and poor families who would receive the same systematic treatment that privileged adult patients have at Jastrow Hospital and Research Center. And that needed a lot of, negotiations, and also, again, outside donations from Rotarians, Lions, and private donors. And somehow or the other, we had already convinced a group of patients from Wadia Hospital that instead of subjecting the children for the painful experience of chronic maintenance hemodialysis or CAPD, it is better that they save the money, and we would try our best to have the kidney transplant as the important, end treatment. This is very clearly shown, and it is again and again reiterated, that kidney diseases gives us enough time to treat the kidney disease at the beginning when hardly any morphological changes are found in the kidney biopsy. And it's only when the kidney function reduces to 60 or below, that means 40% of the kidney is lost, that you get that you can see the histopathology of the kidney done in the human, cases. And there is changes occur in tubules and interstitium, which is called IFTA, that is interstitial fibrosis and tubular atrophy. And hence we decided that we must classify our children also by doing simple tests which was available at that time by Schwartz method of estimating the kidney functions by just height measurement and serum creatinine done by the kinetic method, which is the accepted norm. And this helped us a lot in training the pediatricians who were the first, patient to see the patient, staging the CKD. Now, simple tools for pediatricians for diagnosis of common diseases paid dividend. They also got interested in the follow-up, and they had anyway through Indian Academy of Pediatrics were learning the importance of growth charts and of course the blood pressure monitoring in school-going children above the age of 5 years. So they were familiar with the diagnosis at the level of hypertension and also the growth restriction, where the commonest cause still remains the malnutrition, and the kidney cases giving rise to growth restriction were buried and masked by the primary malnutrition. But after having treated the deficiencies of not only the protein and calorie but also anemia, if there is no response further, and so also was true that those cases of rickets who were resisting the normal doses of vitamin D, instead of keep on giving vitamin D and causing toxicity, we had sort of trained the pediatricians to do the serum creatinine and eGFR by Schwartz method, which was just a calculator which was needed for grading and classifying the chronic kidney disease. And this is the most, I think, revealing use of this simple test to categorize children with chronic kidney disease in 5 stages, and stage 1 and 2 could be treated by the planned treatment between pediatricians with the planning done by the pediatric nephrologist and periodic follow-up. And from 1970 onwards, we did CKD staging in all patients who were attending our pediatric nephrology clinic. And this is the survey which we did under Jyoti Sharma, who was the lead in this in Maharashtra and Gujarat, that is Western India, in 25 pediatric nephrology clinics using CKD guidance. And we found that the causes were nearly the same as in any country in the world. But look at the lowermost column. 22.5% were categorized as unknown cause. And if you see the bar diagram on the right side, we were quite surprised but shocked also to see that for the first time when they sought the consultation by a pediatric nephrology clinic, already 60% of them were already in stage 4 or 5. That means almost requiring the renal replacement therapy for their, otherwise the sustenance and of course the mortality would increase very fast. So there was a dire need of arranging for some sort of a treatment for the so-called renal replacement therapy for CKD 4 or 5, which could be easily, categorized. Next. And hence we had this, which is well known in all the textbooks also, that stage 1, that is GFR more than 90, could easily be treated if the primary disease is diagnosed, which each pediatrician knew how to diagnose nephrotic syndrome. But separate, CKD clinics were for the steroid-resistant nephrotic syndrome as per the guidelines of IPNA, and those with recurrent UTI, those with renal tubular acidosis, and especially Kakut was a big chunk of chronic kidney disease, that is congenital anomalies of the kidney and the urinary tract, especially the obstructive variety PU valve. After the surgical repair and complete relief of obstruction, these cases should first come to the pediatric nephrology for planning the treatment so as to recognize those who require later on, even years later, with the reduction in the GFR, even transplant. We have quite a few cases, at least 3 offhand I remember, who were diagnosed by antenatal sonography, which was very prevalent and easily done by the obstetricians, where the PU valves were suspected on prenatal diagnosis of the congenital anomalies, and subsequent treatment was offered through pediatric nephrologist at various stages of development of that child. And in spite of the best treatment, because the kidneys were already damaged when the child was born, we found that these children slowly went into the CPD 5, and we could plan these children's final treatment with the counseling of the family, and they all opted for kidney transplant. None of them wanted these children to be tortured by chronic maintenance dialysis, which was a very, very painful and impossible situation to sustain for more than 1 or 2 years because of the failure of the vascular shunts or fistula, and also, because of the painful experience of taking the child for the hemodialysis 2-3 times a week, far away from their residence, which took their toll of the family life, as well as it became expensive. They thought that hemodialysis would be paid by some health insurance, or for congenital anomalies, nobody insures the child. And that is why there was a drain on the expenses. So ultimately, they, right from the beginning, some of them said, we don't want our child to be on dialysis, but can we have all the information about what is called now as a preemptive kidney transplant? And of course, by the live related donors, mostly one of the parents agreed for that. And somehow these patients we could manage with a very good treatment of chronic renal disease without dialysis. Some of them required short-term dialysis for preparation, because we knew that the best results are those who are prepared, the recipients are prepared by the pediatric nephrology, and all the necessary investigations are done first, and not pediatric preemptive transplant is never an emergency, but at least 3 to 6 months of preparation goes a long way in final outcome and long-term survival of these patients. So after having identified those with the GFR, which is now falling below 60, and that means stage 3, then all the attempts were made for these children who are constantly under our observation, that is especially the congenital anomalies, and also for that matter the steroid resistant nephrotic syndromes. And at the slightest of dip in the GFR further than 40, we started intervening. Now, the modifiable risk factors we found in many of them, which could still be treated so as to prolong this stage and not to rush into the transplant, were hypertension, which needed the treatment. And by now there was enough material and also evidence on the research that control of hypertension by RAS system inhibitors, that means enalapril or any of these preferred drug, went a long way in controlling the proteinuria, which was another of the important factors which caused relentlessly progressive drop in the GFR, and of course hypertension. So it had a dual role to play. Hyperlipidemia was found, but there was no guideline for its treatment with statins, and more important was a dietetic treatment, and of course a proper drug therapy of the urinary tract infection and prevention of UTI. The role of renal dietitian was stressed at that level at least, and the latest drugs which were in the recent advances were scrutinized, but most of them in the recent article which was in Pediatric Nephrology, like anti-renin drug aliscreen, which was commonly used in adults for the uh, prevention of reduction in the GFR, were not recommended in children yet because of its side effects of hyperkalemia and other. So also anti-aldosterone. So we came back to the same position that to treat all the metabolic disorders like renal acidosis, and that means a complete renogram was a must in the follow-up, and identifying all these factors and controlling them, including the phosphate binders, and that means low phosphate diet, and also the sevelamer and other phosphate binders were used freely. Of course, goes without saying, resistant anemia after correcting the iron and folic acid deficiency were treated with erythropoietin to keep the hemoglobin levels about 12. The earlier treatment of recurrent transfusions was abandoned because that gave rise to more problems later on because of the immunological uh, reasons. So the benefits of kidney transplant over chronic dialysis were so apparent that we didn't need any further, sort of a consultation to the family as a preferred treatment of ESRD, especially in these conditions like steroid-resistant nephrotic syndrome, FSGS, and of course the obstructive uropathy as the first choice. So those who have done very long-term follow-up of these patients, especially the Mayo Clinic's reporting, and also some European countries like Sweden, are very advanced, had published their data on long-term survival in these patients with chronic kidney transplant over chronic dialysis. And the survival was excellent. Life expectancy increased by 25 to 30 years. What do you want? Hypertension centiles were 10 to 20% less. So even post-transplant hypertension was easily managed without much of a drug treatment. Development of cognitive good skills improved. This is the most important plus point in the transplant, so that they can, whatever loss of few school years were there, they could make up very easily. And not only that, they were able to try new skills, and their education was a little late, but still they could continue with whatever they wanted, and their chances of getting employment and other things improved beyond the adolescent and pubertal age. So with all these benefits, there was hardly any argument in favor of kidney transplant. But most important thing was a proper preparation, as I emphasized earlier. So we could delay the transplant by 3 to 6 months. And for in glomerular diseases particularly, since the symposium addresses to glomerular disease, withdrawal of rigorous immunosuppression that has not improved the disease or toxicity took that much time, especially steroids. And not only steroids, but even the calcineurin inhibitor effects were quite deadly, and all the others gradually over a period of time to make room for the new immunosuppressive therapy post-transplant to improve the chance of survival of the graft. A short period of dialysis during this period was acceptable for 3 to 6 months, but never to exceed 6 months. That means we should hurry up the preparation within 6 months, where the donor also is evaluated properly, and also urological surgeries were performed, which were not done earlier, maybe, and especially for the posterior urethral valve, needed to do the bladder surgery, sometimes to increase the size of the bladder to accommodate the adult kidneys demands, And the second thing is a reimplantation of the ureters were preferred, and also along with that the prophylaxis for prevention of UTI, and also the given in the form of either cotrimoxazole, which covered also the pneumocystis carinii. This, during 3 to 6 months, the opportunity was taken to improve the nutritional in our country that decides the final outcome in many cases. Poor nutrition contributes to infection, increase in the infection rate post-transplant, which could be one of the reasons of either the failure or sometimes occasionally the death. And most important for us in childhood is completing the immunization. And for this, the same pediatrician who did the primary immunization was part of this transitioning clinic which we had organized and completed very gladly, and got one of the members of our transitioning committees, which were set earlier for in the follow-up clinics post-transplant. I mentioned already about the surgical correction should be done. So in conclusions, kidney transplant is never an emergency, which was done in the first phase of the pediatric transplant, which I quoted earlier, which was transferred from outside Jaslo with the main purpose of hurrying up the transplant, which they had failed to recognize the in time, the CKD4 and 5, till CKD4 and 5. And good preparation of recipient contributed to successful and long-term outcomes. So this could only happen if the primary pediatrician had a nephrological, training, or it was a hardcore pediatric nephrologist. By now, I had not taken any appointment for the general pediatric, but I was totally in nephrology. And nutrition I had mentioned already, but I have to say that the renal dietitian plays a very important role. Treatment of the existing infection is important because the patient would have a very heavy immunosuppression to prevent rejection, especially in our country. Tuberculosis needs a INH cover or prophylaxis. Hepatitis B, CMV, and HIV also. HIV is very rare in children, of course. And now there is a treatment for hepatitis C. So all these should be covered before you start the immunosuppression. And preferably the patient's age should be between 7 and 12. Why? Because the natural spurt of growth during adolescence and puberty should be taken advantage by the native kidney, that means the recipient's kidney. And then if the transplant is done, there are better results rather than introducing growth hormone therapy after realizing that the child is short and the results are not very good. The weight should be between 17 and 20 kg minimum. I already mentioned about the immunization, but just to reiterate, what are the important ones one should not miss? That is DPT, MMR booster doses, pneumococcal, hepatitis A, B, tuberculosis, and chickenpox. And most important now, addition, because many of these patients who had received the hemodialysis acquire the hepatitis C from the transplant, before the transplant. And discuss with the pediatrician, pediatric nephrologist, pediatric surgeon, and transplant. That comes to what is the team for a pediatric transplant. For every patient, all these are required for the success. Pediatric nephrologist, transplant surgeon, specializing in the pediatric transplant surgery, patients, pediatrician for follow-up, as I mentioned. Supportive specialists are very important to get a good outcome. The kidney might have recovered fully, but the child requires to be, also get the opportunity of developing so that he becomes an able adult at the end of the transplant period. and the capability only comes by developing the skills he desires. It need not be a very highly educative, but at least, they can explore the other possibilities like singing, art, etc., which some of our patients did. And child and adolescent psychologists are very important to bring the child out into the adult way of thinking. They are given the responsibility of their own reports and to keep the appointments, and also to follow the proper dosage of the treatment rather than depend entirely on their parents to guide them. And the education plan is designed, and there are special vocational guidance, psychosocial developmental specialists which help the children and the adolescent post-transplant. And all these were available at Jaslow Hospital for other chronic diseases. So the best part of it is there was a shared, sort of a care from other chronic diseases like cardiac surgery, liver transplant, and malignancy like leukemia, those who are recovered after the chemotherapy, all belong to the same. And wonderful transplant, not only coordinators and social workers, but they also included the developmental clinic to find out the level of development of the children and accordingly plan their education planning, and liaised with the schools which will take these specially abled children, that means having chronic kidney disease. Now, I'm just last part of it is my own experience at Jaslow Hospital. The first phase I have divided into first phase 1 and 2. First phase was starting at 2000 and ending at 2010, and I already discussed that all of them came as a reference from different specialties, and there was no uniformity, and somehow or the other, even the age at transplant in 50% of them was above the age of 14 or 15, where adolescent growth had already, stopped. There were 18 males and 2 females. Original disease was equally distributed between the glomerular and Kumud, that is a congenital developmental defects of the kidney, 1 Alport, 1 drug, and 6 were unknown. So they already were in stage 4 or 5 by the time we realized that the need for the renal replacement therapy was acute. Donor, mother in 12, father in 3, uncle in 2 each. The complications were unacceptable to us, but we had no control over them because they had gone back for their follow-up to the respective referring doctors, and we was playing a secondary role, only invited when some complication occurred. 3 had acute rejections and 1 had death. So we said something better should be done when we are fully in charge of the patient right from day 1 of diagnosis till, of course, the transplant is completed. And we opted for preemptive. By preemptive does not mean that no dialysis, but short term of dialysis only while preparing the patient was our criteria. 14 of them. Now these slides are meaningless unless I show you the comparison of phase 1 to phase 2 and what were the sort of important lacunae. And the most important thing in phase 1 and phase 2 were 6 were unknown, as I mentioned, and were admitted directly from ICU, who had given the hemodialysis or CAPD as the mode of treatment for their end-stage renal disease. And the preparation was not done according to the guidelines as per pediatric nephrologist advice. Some of the immunizations were missed also. And control of BP was not very good. And dialysis were given in 5 patients for hemodialysis for 4 to 12 weeks, only while preparing. So immunosuppression used in both phase 1 and phase 2 were the same, but additionally the TAC levels were done in the patients where I had the full charge of looking after the pre-transplant and post-transplant follow-up, and specially recruited in the transitional follow-up clinics staff of my choice who were familiar with my requirements. The transplant had two intrasurgical complications in phase 1. One of them had a clotting in the major vessel of kidney and required immediate consultation with me for anticoagulation therapy, and which fortunately they didn't lose the graft, but I'm sure the graft had already suffered, and later on we don't even have a proper follow-up of such child. The procedure and the progress in the second was much better, and there were equal distribution as far as the donor, there's nothing to choose. And the type of transplant done in each category, that means early phase and were almost equal 6 and 5. And the only other difference was a longer duration of pre-transplant hemodialysis, which went on for more than 16 months unnecessarily, because there was a very slow progress in preparation of not only the patient but also the donor. And that is what made that category more vulnerable to complications. So the next few slides will show us that what are the complications of this transplant in the first year of follow-up. And very starking is 1 death and 3 acute rejections, as I mentioned earlier. And the death was due to Pseudomonas, and this patient had received a very long course in the ICU outside, and then transferred when they could not manage, and then suddenly they landed up in Jaslo. I could not refuse them. And toxoplasmosis of brain in one girl, of course, she survived that. And this probably was a hidden infection which got flare up because of immunosuppression, and fortunately responded to clindamycin. She is now a beautiful 22-year-old girl, still on clindamycin prophylaxis and anticonvulsants. And the phase 2, where we had full charge right from the beginning, I had no major complications. So the follow-up period was again showed after 10 years of follow-up, which was so encouraging, that this was a sample size of these 5 cases, which we always projected for, and gave the addresses of these patients who are now beyond our age. That means they were all in their late 20s or early 25 years, so up to 25 years, which was allowed by the WHO as considered as a pediatric transplant follow-up cases. They did not want to go to the adults because they were not familiar with them, and they were so familiar with the whole friendly atmosphere in the follow-up clinic of pediatric transplants that they preferred to come to us, but we had to wean them off us. So the case 1 has become a lawyer now. And the last time that we followed, his serum creatinine is only 1.17. And the age at transplant was 11 years. If you find that all of them were in the age group where the natural growth was taken, and none of them remained very short or dwarf. And the second one is a girl, reflux nephropathy, first transplant given by the father. And the second one, because there was a chronic glomerulopathy. She was working in a banker. She took a loan from the bank and she paid for her own transplant second time, and she got a disease donor transplant. Remarkable. I mean, this was an adult type of a decision. She didn't rely on her parents anymore. An infantile nephrotic transplanted at 11 years, last seen 1 milligram, student doing some research study for PhD in USA, very encouraging. And the 4th and 5th cases I will elaborate in the next slide. And these are the 2 cases which I want to illustrate. Both these children, one had a glomerular disease, that is steroid-resistant nephrotic syndrome, one wearing the red cap. And he already was on hemodialysis initially with the 2 failed vascular access, and then on CAPD. The mother was the transplant donor, because she said, I don't want my child to be tortured anymore, and I am now ready for as a donor. Now look at her malnourished state. She was obviously from our follow-up clinic in Vadia Hospital, and I brought her to Jaslo and admitted her for her nutritional rehabilitation and ultimately a very successful transplant at the age of 11 years. And now the boy is 22-year-old. He wants to be a singer. He's got a good voice and he trained himself because he was not interested in academics and very poor anyway. And the other one was, so aim of pediatric care has helped in getting these children, except for dwarfism, which we could not help because of the late. And that, I think, ends my journey for a preemptive transplant as superior. And I have already, presented these 2 sets of cases, first in Shanghai, China, and the second very recently in Italy with my colleagues, and I thank all of them. And now it has become for us a challenging job to tell when not to do the preemptive transplant. And so the new concepts which I have to, new concept which we had put in practice, which was formulated by Alan Watson of Nottingham, is we should start these transitioning clinics for continued benefits from transplant, even in the early adult life. Pre-transplant counseling, preparing from the teams, forming the teams, and same supportive staff for critical period and actual transplant and immediate transplant care and follow at least for 1 year has the best results. Long-term transitioning clinics involving school, college, vocational guidance should be set up during this period, and proper advice, if taken, these children can become self-sufficient adults and can take care of themselves. And the psychologist's opinion and, if needed, psychiatric treatment helps them. And what is important in India, there is something called corporate social responsibility schemes for all the industrialists to invest at least 10% of their profits in such activities. We should tap them, and we should never say that now we are not anymore low resource countries, but these resources need to be consolidated from various people, and the patient should not feel that he is getting an inferior treatment. And I thank profusely Jaslo Hospital, and I will be failing in my duty if I don't thank Kalaivani, who helped me a lot in coming to this last part of it, which I was quite diffident in between the 2 stalwarts who were my co-people. Thank you.
Thank you, ma'am. Just a small request, Flynn sir needs to leave for his office. So we'll just take up Flynn sir's question first. Flynn sir, are you there around?
Yes, please.
I'm here.
Yeah. We'll just have few questions from the participants. The first question is, how to interpret with only elevated load?
Excuse me?
How to interpret with only elevated blood pressure load?
You mean blood pressure load without elevated mean blood pressure?
Mean.
In the American Heart Association statement, that would be a patient categorized as having pre-hypertension and not into one of the other 4 categories, which is a bit complicated, and there's been some question as to whether that is a meaningful category or not. But I think that's a question for another day, a longer discussion.
There are a few other questions, sir, but I think we'll just mail you all the questions. Like you can give your thoughts on the series, sir. Like I think we should not be disturbing your routines because we are like you have to leave to your office.
Yeah, I apologize for the tight scheduling, but I have some patients scheduled for a little bit from now. So I appreciate the opportunity to have participated in this course. In looking through the list of talks and so forth for the series, it really has been an academic feast, is the words that you've been using in your emails, with quite a comprehensive view of pediatric glomerular disease and hypertension and kidney transplant. And I am very impressed by the breadth of the topics covered and the number of speakers. And I know that I had been told there was quite a good attendance, at least from the one prior session that I participated in. So I do hope that that has continued through the whole series and that people have found this to be a very useful educational endeavor. And I think it's interesting that, you know, we have been able to put together things like this during the coronavirus pandemic and take advantage of the use of technology. And I think in some respects, it's taught us that we can actually interact and learn from each other without being in the same place. There is no substitute for a live meeting and talking to people in the hallway and at the coffee breaks. But so I think that moving forward, we'll most likely see a combination of virtual sessions like this one and live meetings. I know that, for example, in September, the European Society of Pediatric Nephrology is having a hybrid meeting where there will be some people present in Amsterdam and other people participating remotely. The American Society of Nephrology is doing the same thing in November for the Kidney Week meeting. And I know that it's being considered for the next IPNA Congress as well, although I haven't heard the final outcome of those discussions. So again, I think it's been a great experience for me to participate. I hope that everyone has been able to come away with some new knowledge, and I do hope that eventually I'll be able to come visit all of you in person at some future meeting. Thank you very much.
Thank you so much, sir. It has been a wonderful time listening to your talk. It was like dream come true, like having you interact with all of you. Thank you so much, sir. Namalvar sir and Thangaveelu sir, would you like to tell a few words? Sir, is it okay if we can mail the questions to you, sir? Is that fine?
Yeah, I am going to sign off, but
Yeah.
People should feel free to drop me an email with their questions.
Sure, sir. I'll just mail you the questions across, sir. Thank you so much, sir.
All right. Bye now.
Thank you so much, sir. Bye-bye, sir. I request Namalvar sir and Thangaveelu sir to share few words.
Sir, Professor BRN sir. Namalwar sir.
I think Namalwar sir's is freezed or sir is there.
Professor Biaran sir.
Yeah. Go ahead, Tagvelu.
Sir, please, sir. You just, sir.
No,
please,
you
sir.
speak first. You speak first.
So nothing more, sir.
I love to listen to you. Please.
Nothing like that. Anyhow, Professor Joseph Flynn has left. A big thanks to Professor Joseph Flynn. We are really proud to have him as a guest speaker in our web series. Not only that, he is the world authority in hypertension, but his talk was so simple and highly informative. And of course, the organized team personally wants to thank him. I don't know whether it will be conveyed to him for adjusting his date and time to suit the schedule of our webinar series. And Professor Georgi Abraham, sir, your talk was very inspiring, even for an old man like me. It evoked multiple emotions in the minds of a pediatrician: success, compassion, knowledge, innovative strategies peculiar to India. Your book, My Patient, My God, is really great, sir. I want every doctor, young and old, to look at you for your life and book and learn to choose their objective of life. I will just repeat, every doctor should look at you and your life and your book and to learn to choose their objective of life. It's really great, sir. Madam Kumud Mehta, Madam, you said it is a very simple this thing. In simple words you told, but it is something more than that, madam. Size never matters. Pacemaker is a very tiny tissue in the heart of a 60 kg man. But that is the beginning of life and that is the center of energy of life. So along with Professor B.R. Namalwar, Professor Srivatsava and Professor M. Vijay Kumar, you created the specialty of pediatric nephrology in late 1980s. I think maybe 87 or 88, sir. Late 1980s, the specialty was created as a small plant. Now it's grown as a big banyan tree with a lot of pediatric nephrologists. In fact, we have 3 pediatric nephrologists in Mehta Hospital. Salute to you, madam, because you have given new life for many kids. We have seen how your children have grown like a singer and other professionals. Thank you very much. Professor B.R. Namalwar, again, it's a mentor for me as well as for many of our colleagues. You are considered as a father of pediatric nephrology in India, and your contribution to the development of specialties can be really great. You are responsible for bringing a lot of specialties courses in South India as well as for producing many pediatric nephrologists. And to taking care of this. Can I continue, Kalevani? Some distance.
I would be failing in my duty if I don't thank Mehta Hospital administrators for the continuous support to the academic side of the nephrology, and which helped us to deliver a very good for the children with these academic sessions for the younger generations. Thank you.
Though it is not a customary to thank the host, I sincerely thank on behalf of all the students and faculty Dr. Kalevani for this mammoth effort of organizing a 16 webinar series involving great national and international faculty. Thank you very much, Dr. Kalevani, for this wonderful webinar series. It's made us to learn a lot of things.
Hello, can you hear me? Hello.
Yes, sir.
Yes,
We are able to hear you, sir.
Hello.
Yes, sir. Yes, sir.
Yes, sir.
For Kalavani.
We are able to hear you, sir.
Hello.
Sir, we are able to hear you. Thangavelu, sir. Kannan, sir, is there around. Sir can say a few words.
Yeah, I request Kannan, our medical director, to say a few words about the.
I'm able to hear you, sir.
Yes, sir. We can hear you,
we are able to hear you.
Hello.
Please go ahead, sir. We are able to see you and hear. Dr. Kannan, sir.
Yeah. Okay, good evening, everybody. I feel immensely proud that Department of Pediatric Nephrology in general and Dr. Kalaivani in particular is able to organize this wonderful webinar series consisting of 16 sessions. No, it is a mammoth effort in association with IPNA and IPNA. In Tamil, the number 16 has got great spiritual and religious connotations. Because in Tamil, we always bless the elders, bless the young couple, that they get 16 blessings as soon as they get married. Like that, she conducted 16 webinars of great academic and practical significance. It's a feast to academic feast to all the students as well as practitioners, general pediatricians. And profuse thanks to all the eminent personalities, eminent nephrologists who gave us scintillating lectures. And of course, a special thanks to all the delegates who had the benefit of this knowledge. Let knowledge and wisdom come to you from every side. Let noble thoughts come to you from every side. And the Upanishads. Thank you.
So, Professor B.R. Ansan, Kamalwar sir. Sir?
Good evening to all of you. To begin it, I must thank Dr. Kalaivani for giving this wonderful privilege and honor to chair the sessions. Dr. Kalaivani is single-handed and has conducted this webinar program exceptionally successfully. I would say she laid a new path in conducting education. The last time it was about nearly 30 or 40 lectures, and this time another lot of lectures. And everything lecture was a gem, and given by teachers who are themselves gems. Where would I get an opportunity here, Dr. Flynn? Where would I get an opportunity to listen to Georgi Abraham? Where would I get an opportunity to listen to Dr. Kumud Mehta? Dr. Georgi Abraham, to me, is a philosopher in nephrology rather than a clinician. His talk, his behavior, his language, his contribution to society is great. And I must acknowledge now that he is one of the world's first persons who started CAPD in Chennai, and my earliest patients were with him. He used to look after those patients for a long time until I was a child test. So I am always grateful to him for that. Second thing is Dr. Kumud Mehta has been an old friend for more than 30 years, for more than 40 years. And she always carried herself with great magnanimity and graciousness in what she did and spoke. And today we heard her speak a simple, straight, and striking presentation. Of course, I'm not fit to talk about Dr. Flynn, who's a great philosopher, who's a great scientist and a nephrologist. Then I thank Dr. Thangavelu. Thangavelu is much younger to me. He's my colleague, but he's my colleague. He is a combination of high quality training educationist, high quality philosophy in life, morals in life, and a good human being. It's a rare combination. And rarely I heard him getting angry with anyone of them or even complaining about it that he gets angry. It's such a wonderful child, and it's an example to all our postgraduates. And the next thing is, I must thank all the people who are all the audience or the attendees who to all this class, who patiently listen to us. We thank them, welcome them again. Then we'll thank IPNA for sponsoring this wonderful program, but for their support, I do not know whether you could have done anything better than this. Lastly, I must thank the IT department of Mehta Hospital for always stood by us and see that the whole thing went without any hitches. And last but not, I'm not saying, I'm going to say goodbye, but I'm going to say au revoir. That means we're going to meet again. And when Dr. Kalaivani will tell us. Thank you.
Thank you, sir. Kalaivani, vote of thanks.
Thank you so much, sir. Like, if I have to put everything in one word, I think this program was basically successful only because of great teachers and their guidance. I should really thank Namalva sir, Thangavelu sir, and the whole Mehta Hospital team and the administration as well. That would be the apt word. Like, I think it is a blessing of all the teachers. And I take this opportunity and I deeply appreciate all the faculties of our webinar series who are the real strength of any academic program. And special thanks to IPNA, who had laid a great foundation, and it has been a great platform to excel the academic programs. And the best thing the COVID has done is it has made us all connected from various countries. And I am really excited to tell that this webinar series has almost reached, or almost this 16 series has reached around 78 countries. And it has covered almost 481 cities and 1,351 individual hospitals, and it was really a proud moment that it has reached so much of, it has reached globally. And it has all happened only because of all the teachers' support. And the best thing is the faculties or the real support. I should really thank in the present forum, I should thank Kumud Mehta madam, I should thank Namalva sir individually, I should thank Dr. Georgi, I should thank Dr. sir individually. Thank you should not be the word. They deserve much more. Thank you so much. Thanks for making this program a successful event. Thank you so much, madam. Thank you, Kumud Mehta, madam.
Thank you.
Kalivani, the team also includes our IT team, Sivakumar.
Yes.
Yeah.
The whole
He
IT
needs
team
a special
as well.
thanks. But for
Yeah,
but for him, it may not. He's the energy
yeah,
behind
that's
this.
very true, sir. Very true.
Okay.
Namalva sir has thanked
On
the
behalf
whole
of you, I
IT
thanked
team.
him. Okay.
Yes, sir. And the designing part of the whole, the invitation was just like a masterpiece, which was done by Sendil, and the coordination was done by Mr. Joshua, a medical social worker. I think Namalva sir thanked the IT department, so I did not come forward to thank them individually. Thank you so much, sir. I should really thank all my teachers. Thank you, Georgi sir. Thank you, Kannan sir. Thank you, Namalva sir. Thanks, Kumud Mehta madam. Thanks for making the day so pleasant.
Don't make it so.
Thank you, sir. Can we close the session, sir?
Yes,
Thank you, Kalami.
Yes, sir.
Kumud Mehta madam, you wanted to tell something?
No, I wanted to clap after you.
We will clap with him, madam.
People who are involved in this. I can't think, even Mehta hospitals, I think I did not thank enough because of their academic interests, which will be translated into the care of the poor patients and care of the deserving patients. That those are small children, and they don't know how much contribution Mehta Hospital has done to their well-being. Thank you.
Thank you so much, ma'am.
Good night, Dr. Kumud Mehta. My regards to Dr. Uma Ali.
Yeah, of course. I hope she's watching this. I'm not sure. She's.
I always think of the conference conducted in Bombay, the glomerular nephritis. The good food you gave, and Mr. Mehta coming every day in the night and giving fruits to eat in the hotel.
You
can't forget
remember him and the good food, huh? You don't remember. Very good. He was my main strength and the backbone for my success. No more there, you know that. Thank you. Thank you for remembering him.
Good night.
Good
night,
Thank you,
Georgi.
Georgi sir, thank you. Georgi sir somehow was not able to speak. I think his connectivity is lost somewhere.
Bolu, Georgi.
Namalva sir, shall we wind up the session? Thank sir.
Yes,
you.
please.
Good night.
Yes.
Thank you so much, sir.
Privilege,
Good night.
and honor. Thank you.
Thank you, sir. Good night, sir. Thank you, madam.
Dr. Kalavani, convey my regards to Georgi because he had hosted me once and I had my memorable meeting with Professor Brenner, the topmost nephrologist in the world, who gave me this idea that look at your congenital anomalies of the type and you will do great in starting the thinking about the end-stage renal disease right from their birth, which was so depressing to me. But that's true. Thank you.
Thank you, Kumud Mehta, ma'am. Thank you so much.
Thank